Hi, good afternoon. So my name is Sammy. I presented at this conference last year, so it's very nice to be back again. Just let me know if you can't hear me very well. My talk looks at theatre efficiency and standards of care during the COVID-19 pandemic, what we've learned and how we can improve on our current standards of practice. So just a little bit of background about how theatre has changed for many of us, I'm sure. Just as in terms of two lines, what the pandemic has really meant for the world: 219 million cases and 4.5+ million deaths, and that's accurate from yesterday. So that's going to continue to rise. It's had a major impact on every surgical specialty, and although I don't think we were very wasteful with theatre time beforehand, but if we had a cancellation before the pandemic, I don't think I would lose too much sleep about it. But now a cancellation means that not one, but maybe two other patients are unable to have their surgery, and you haven't used that time effectively. As we all know, it takes a lot longer to take a patient to theatre now with all the checks, etc. Because the landscape keeps changing and more publications come out, all the evidence is very new. It's meant that our anaesthetists and surgeons have to change their practice around surgery, prepping the patient and increasing recovery time. And overall, this means even a routine procedure, like maybe doing an abscess drainage, can take a lot longer than it would previously. In the United Kingdom, we've had multiple lockdowns and delays in restarting, especially our elective operating lists. And one analogy that was mentioned to me is about countries who experience multiple earthquakes, that you have a lockdown, you have an earthquake, and then you're finally getting back on your feet. You're redeploying people back to theatre and back to surgery, and then you have another lockdown because the national guidelines require it. You have another earthquake and you're back to standstill, and you haven't actually achieved anything. And in that time, your waiting lists are getting longer and longer, and patients are suffering, waiting for even routine care. The need to be efficient in theatre is to try to maintain gold standards of care. And in the orthopaedic setting, a key example is with neck and femur fracture management, where in the UK, there is a financial tariff given to hospitals if you are able to achieve neck and femur fracture surgery within 36 hours. So that's a reason to be theatre efficient, especially with these time critical cases, and to reduce the waiting times of patients still waiting for surgery in due course. These are some quick figures about those patients who are actually waiting for an operation presently. As of January 2021, these are just the patients who are waiting over a year. You're nearly 400,000, and the Royal College of Surgeons of England has that figure close to about 700,000 now, and about 2 million for all patients waiting for surgery. So those waiting under a year as well. So we've got a big backlog. The aim of my project with my colleagues was to identify how the pandemic has impacted orthopedic practice and how we may try to improve theatre efficiency. And that's relevant pan-specialty to all surgical specialties. We used a thorough systematic review of the literature on PubMed, using the keywords mentioned here, which gleaned 20 studies, and we had inclusion criteria to try and keep things quite uniform, just looking at orthopedic operating, relevant to theatre time efficiency in the pandemic. And when excluding the duplicate and low evidence papers, so editorials and case reports, we had 12 studies at the end, of which 6 were observational, 3 were systematic reviews, and 3 were expert opinions. There were some key themes that came back throughout all of these papers, key recommendations which have been adhered to some degree, I'm sure, in all of our centres. So the first and foremost being the need for PPE, to have key donning and doffing areas around your actual theatre that you're working in, and to try to think about the effect of PPE on surgeon comfort and maneuverability. And I'll touch on that a little bit at the end of my talk. The need for decontamination between cases of patients and all staff. There were initial recommendations for all intubations and recovery to be done in theatre, And this has now tailed back as recovery and intensive care areas have become more accustomed to managing COVID and non-COVID patients outside of theatre settings. There was also a suggestion to allow theatre air cycling for 20 minutes between cases. And in my practice, we try to use laminar flow theatres as much as possible to reduce the risk of contamination. We have noted the need to be more frugal with our use of supplies, so not just to open something willy-nilly and then throw it in the bin, only to open it if you need it, and have runners available at all times in theatre to reduce the time needed intraoperatively. And there's also been various difficulties with getting COVID swabs, I'm sure, everywhere. And that has improved as newer, more rapid swabs have become available, but it's very much based upon the ward healthcare staff and junior doctors when that patient comes in overnight. So we're talking about trauma, that swab is sent off as urgently as possible, as there are unforeseen delays. Maybe the porter doesn't come in time, maybe it doesn't get to the lab in time, maybe it's lost and you need to send another one. So these have been highlighted through audit practices in numerous centres around the West Midlands where I work, in the Queen Elizabeth Hospital, Birmingham, to try to expedite these swabs as soon as possible. All of these things I've mentioned add to your delays for theatre and increased time in theatre required just to do one case. This is a list of the studies that we looked at. And on the left-hand side, you have the cases completed in April 20 or around a few months during the pandemic. And on the right-hand side, you have a corresponding month in 2019 looked at retrospectively. So in terms of efficiency, you can see that looking at the red column, the percentage change, all of these papers, apart from one, noted that there was a significant reduction in the operative capacity, the number of cases they were actually able to do. And some of these papers are very high numbers. So previously, if you look at the Andreatta paper, which is probably the most interesting paper that I read, had 537 cases outside of COVID, and they were more than half that afterwards. The Arafa paper at the bottom is the only paper which contradicts this, but they looked at neck or femur fracture only. And given that we had cut down all elective operating and we're only doing trauma in our centres primarily, or cancer work, neck or femur fractures and other trauma cases were prioritized. And as I've mentioned, NOFs would usually go first due to the financial tariff and national guidelines in the United Kingdom. So since they only looked at NOFs, it's a bit of an anomaly. And I'm sure if they had included all of their trauma, you would find a reduced capacity overall. The case series in general noted significant delays looking at the turnaround time between cases. And this was often up to 60 minutes and attributed largely to requirements to deep clean theatres, need to recover patients in theatres. There were various papers that also noted significant delays in starting. And that's something I've experienced during the pandemic. No matter how early you're rounding and seeing your patients, you're not putting knife to skin at the same time as I was in 2019. So these two papers highlight, 16 minutes and 19 minutes in 2019, and 2.5 hours and 48 minutes on average in 2020. There were more late starts and there were much fewer early starts. So we're not even talking about starting on time, but pre-pandemic, these papers noted 35% of lists were starting before, if it's 8 o'clock or 7:30, whatever was relevant in those countries, they were starting early. And now that just wasn't possible. Theatre capacity was also reduced, partly due to reduced staff, redeployment of labour to other areas, A&E, medical wards. Certain theatres were not appropriate for COVID care and therefore were not utilised. And any cancellations meant a 3-4 hour loss of theatre time. In terms of case completion times, this is very interesting for me, and I would agree. The time taken to do, these are key bread and butter orthopaedic trauma cases, DHS, ankle fixation, femoral nailing, which you'd be looking to do in about 60 to 90 minutes. The mean increase in theatre time was up to 80%. So you're looking towards 2 hours to do a DHS case. which is quite abnormal outside of the pandemic. And this was largely due to donning and doffing and cleaning, not the actual operative time, which was around about the same in all of the Mathai cases. There were some recommendations from some of these papers. The BAT paper, which is from India, noted their use of a detailed dynamic protocol to care. So this was a very strict protocol applied to every single member of the operative, anesthetic, and theatre team. Each person was given a clear team to be a part of and key tasks that they had to do at certain times of the day. There were hour-by-hour plans for those members of staff as to what they should be doing and where they should be. This practice was then redefined through the pandemic as new evidence emerged and was practiced in simulation sessions. And they found this to be quite successful to reduce wastage of theatre staff and confusion in theatre as to who should be doing what. The other paper I noted something interesting was Chatterjee, which noted about refinement using new evidence-based practices. As I mentioned, these were arising. One thing that was done in numerous hospitals in the West Midlands was employment of staff who were specifically utilized for COVID. Instead of, as I've noted in other areas, hospitals were allocating these roles to people who already had existing jobs and therefore could not give their full attention to these roles. So this would include staff who had a background of clinical and surgical experience, but were tasked with looking at emerging literature and having access to management at the highest level so they can change the practice immediately with guidelines for those hospitals based upon the practice that was emerging. And their role would also be to disseminate this directly to the healthcare workers on the ward. And as I'm sure we can all appreciate, this pandemic has required us to change our practice sometimes on a daily basis. And the confusion it creates, because you have an anaesthetist who will say one thing, a surgeon who will say another thing, and a healthcare practitioner, a junior doctor on the ward, who maybe have not received the current up-to-date guidelines. And that confusion can mean everyone feels that they're doing the right thing, but actually it's not what the hospital requires or the national standards require you to do. And that in itself is creating a delay. This is something that I came across. It's not relevant to COVID theatre efficiency, but it's relevant to PPE and the future of what we should be doing, as the pandemic is going to continue to some extent, and for future pandemics which may rise, very possibly. So this is a paper by Benitez from Spain, who took questionnaire data from about 250 surgeons from 21 different countries, outlining their opinion about PPE and their ability to deliver surgery. Now, some of these numbers are very interesting, and I can say wholly true. Surgical fatigue, they said, was 82% higher with these, very non-breathable gowns and things that you have to wear. And I can genuinely agree with that. As a junior surgeon, I want to do as many cases as possible, but sometimes you're finding yourself wishing that we need to get to the end of this case because you're just sweating and burning and ready to pass out. And then probably the most relevant one is at the bottom, surgical performance compromise. More than half of your ability was felt to have been lost by having to be in these very complicated devices at times, with a respirator, with reduced visibility, reduced ability to communicate even with your assistant or scrub nurse who are standing next to you, to the anaesthetist who are slightly further away. So the future of the PPE needs to be centered around actually surgeon comfort, because this is going to allow us to do our jobs properly and reduce the risk of complications arising, which is going to make the patient's healthcare pathway much more complicated. So in conclusion, it's been a very difficult period of ever change, and we're not quite there yet, although things are improving. There remains a need to educate relevant staff consistently, and I think I've noticed in our hospitals having new employed staff whose role is just to read guidelines, just to speak to management and only to disseminate to other staff, to be highly useful, rather than having a person have to do their normal job, maybe as a scrub nurse, and also disseminate information. It's not really what you want. I thank you for the opportunity for allowing me to speak, and I hope you all stay safe. Thank you very, very much.